Good afternoon. My name is Hope Frost, and I'd like to welcome you to today's webinar on empowering your patients to self-manage their diabetes. Before we get started, I would like to thank Abbott for sponsoring this webinar. So it is now my pleasure to hand over to your wonderful webinar chair today, who is Iain Cranston from Portsmouth Hospitals NHS Trust. Hi, Iain.
Hi, Hope. Thanks very much, and welcome everybody to what I hope will be a really inclusive hour of continuing education. It's my great pleasure today to chair one of my colleagues in Portsmouth, Professor Partha, who is one of the few people, I guess, in UK diabetes who realistically needs no introduction. You'll be aware he's the National Specialty Advisor for Type 1 diabetes and is also one of the very few people, I suspect, within our specialty who's probably visited virtually every diabetes centre in the country in his role with the Getting It Right First Time initiative, which he's a co-lead of for diabetes. Most of you will be aware he has a very high profile educatively and particularly in social media, and has undertaken a number of really very high profile causes to try and improve both the living with and outcomes from diabetes. One of those that most of you will be aware is very close to his heart is the issue of effective communication. And that's what he's going to talk to us a little bit about today. And in particular, this issue around empowering people with diabetes, both in a motivational sense, but also with the tools they need to make the difference for themselves. So without further ado, I will hand over to my colleague Partha, and I'm looking forward to hearing his views.
Yeah, so I've been asked to talk about, generally our language matters, what it is. So I'll give you some basic principles, we'll talk about it, and then of course we'll take some questions and me and Iain will have a chat. So going forwards. So I always start with this particular piece of information which people always ask what it is. And it's simply put, that's on average is the amount of time that a patient with diabetes will actually spend with a clinician in the NHS. And as small as it sounds, that's actually quite a generous amount of time that people talk about. So if you think about it, there's 8,760 hours in a year. And with the best will in the world, let's just say we see each patient 4 times a year, half an hour each one. You're talking about 2 hours a year. That's about 0.02%. And as we all know, we're all scrunched for time. And the fundamental point of giving that particular number is to say that actually the person with diabetes, or for the matter, any chronic disease, ends up living with what they have for 99.98 to 99% of their time, which is, as you can imagine, a huge, huge proportion of their total time. For me, I think what I always talk about is diabetes sitting on three particular planks. And I think if we tackle those three, then we probably will make progress as far as looking better outcomes of people with diabetes. So self-management, peer support, and access to trained professionals. And I think those are the three main things that we talk about. So if you look at the NHS way of working on in most healthcare systems, we spend a lot of time on number three, trying to get more doctors, more nurses, more et cetera, X, Y, and Z. The problem, as you all know, we just don't have enough of them. So you can try as much as you want, but even if you got double the number of resources we have in the NHS, which is not going to happen, then you're probably talking about still giving maximum, you jump up that figure of 0.01% to what, 1%? And even then, 99% of the time, people live on their own, living with their diabetes. So self-management and peer support being some of the key markers if you want to improve care. And that's why a lot of the technology work that we do, a lot of the things is centered around how do you help self-management. So is the education programs, etc. This is a slide from one of my colleagues, and it doesn't need to sort of labor the point. As you can see, many, many things with type 1 diabetes, type 2 diabetes, not very dissimilar. So many things to sort of play with. And this is what people live with day in, day out. The bigger question is, whose target is it when people come to their clinics, come to our clinics? We talk about blood sugar, HbA1c. Is it important for the person? We talk about weight. Is that more important for me or the person sitting in front, hypoglycemia, well-being, and the whole concept of engagement? So if you think of a lot of, And the reason I put this there is that we spend very, very little time with the patient in their life, 0.01%. So what impact we can make has got to be very focused, very, very important, and very, what shall I say, very much concentrate as to what benefit the person can get out of it. So that little time we have for that person concerned, that person is really little. So what is the maximum impact? And the maximum, or the minimum we can do is not being rude, not being impolite, not being judgmental of people. And that's the sort of concept of this. I show you this particular slide because of a reason. I'll show you in a minute the reason for it. But if you look at this, this is what's happening all around the world. This is from January 21, 7.83 billion people, 4.6 billion people on the internet, 5.2 on unique mobile users, and then social media users. Why do I use this? Here is a particular reason for this. This is a recent paper which has come out. And this gives, even though it's a bit of a bubble and then not a lot of people, but just to give you an idea, there's a truckload of people using social media to discuss their diabetes. And have a look at some of the important points for type 1 diabetes and how it sort of translates with us and how we believe things to be. What do you think are the top few things? Well, there's that COVID spike, as you would expect, during the COVID months, so to speak, when it first broke through, and then the second wave, etc. But have a look at as to how high diet continues to be right at the top of the tree, even with type 1 diabetes. Tech and devices are there. Seeing a healthcare professional, much, much lower down the tree. So it's very important to have an understanding what people are talking about. Does it actually match with what we think to be important for people living with type 1 diabetes? Type 2, here we go. Very similar, but interestingly, COVID was important, but never actually surpassed the importance of diabetes. So you can see, topics being discussed may or may not be the same. And you can see why diet is very important as we go along. And the reason I put this across is social media or wider forums or lecturing and meeting with patients. When you would go wider, you have a very better understanding as to what people are talking about, what is important for them in that 0.01% time that they spend with you. What is technology? And it goes back again to what I say, it's simply an enabler. That's all it is. It's a quality of life issue. It's a visualization, self-management. And when we talk about the concept of language, I think it depends as to how we see technology, being the vanguards of who shall get it and who shan't get it. Technology is important because it becomes an enabler in the self-management. And I think that's important as to the language shift as to what we are trying to do, that it's not us holding the sort of bars as to who can or cannot get anything, and what resonates with people living with diabetes. And here's an example of what I talk about when we talk about language. This is all of us, we're afflicted by that, so to speak. It's, in psychology terms, it's called Rosie retrospection. You've all heard about this. People, as we grow older, we sort of hit our 40s, then 50s. As we go older, we would like to all think about our time. And, and as a doctor, we are very much drilled towards, in our time, we used to work harder. We used to be, our junior doctors were, they're not as hard as us, and we would work long hours, and we would never sleep, and we would grit our teeth. And aren't they a bit of like a snowflake in the millennial generation and always wanting time off and holidays? What's that all about? But that in psychology terms is called Rosie retrospection because of many, many data to support it. Here is one example. Teen births plummeted since the 1990s. And if you look at it, that's a lot of it is because people also are more sensible than what we used to be. Here is some my other in my time slide. And this is a fantastic, if it does, apology if it doesn't come across, you can have the slide. But if you look at this, whether it's, trying a cigarette, trying marijuana, had sex, unprotected sex, got in a physical fight, every single marker, drink 5 or more drinks in a row in the last month. Generation now is much more sensible than generation us or me, for example. So I think there is a belief that we have, and that sort of reciprocates in our language and our thought process. And think of the adolescent clinics that we do, a natural tendency to believe that, they're teenagers. Teenagers are quite sharp, in my view. I think it just needs to engage. You need to find out what engages them. I think coming into that with that judgment that they will not engage and there's no point, I think just shuts the door. As I said, 0.01%, that's just an hour of their life, right? And if in that hour, we can't build that rapport, the relationship, and maybe not talk about their diabetes, that's quite an important thing. Here is something we have used in the past in some of the clinics in Portsmouth, where we try and ask the patient what they would like to talk about. And I'm always fascinated. There's a particular column here which says, I can't be bothered, when people sort of tick that box. And you always wonder why they have turned up. And invariably it's because their parents have forced them to come along. And you know one particular fundamental thing, they're not interested to talk about their diabetes, but more importantly, when the relationship with their parents will, you know, fracture or whatever, becomes a bit more loose, or they probably won't come back unless you've given them a reason to come back. That is, you're talking about something that matters to them. Maybe they don't want to talk about their HbA1c or how many times they're stabbing themselves. Maybe they just want to talk about how to deal with life in college and how to deal with the traumas of, you know, girlfriend, boyfriend, breakups, etc. You know, living with diabetes, sex, etc. So different things which are important to bear in mind. So the journey of this started a little bit in Diabetes Australia in 2012, and our position statement, which is out there in the public domain, done by Jane Spate and Renza, who have done this work in 2012. And that was a charity organization, a patient organization in diabetes, which did it very akin to Diabetes UK. Then I remember going to the American Diabetes Association in 2017, where I heard Jane Dickinson talk about the importance of language, heard more about the work from Australia. And in October 2017, this was published, which was talked about the use of language, again, done as part of a cohort. And one of the things I came back, because I just started the national role in those days, 4 or 5 years ago. And I thought, but there's no reason we can't do this in the UK. Well, one of the flaws that I picked up when they'd done it is that because they were done by certain groups, they didn't have sort of much more wider percolation in the system. So we came back, and one of the things we did, as a lot of you will know, in the UK, there is no lack of organizations interested in diabetes. We nearly went through the whole gamut of the alphabet trying to find all the organizations we interested, but we got everybody involved. And we also went to the Open University to actually find out, is there any mileage in doing this? What do people with diabetes think? Or is it just a politically correct thing to do? Where we discuss about, oh, should we call them diabetic or person with diabetes, etc. So we did pretty much, we invested in that particular sort of ground research by the Open University to go around and ask what people thought. So some of the research, I'm not going to read everything out for you, but I think it's important, and I think do take a moment to read this particular statement. But I think for me, it was the last bit which says life gets in the way. And I always give an example when for people living with type 2 diabetes, one of the fundamental things we always tell our patients is, you know, what you should do is you should eat healthily and you should really consider exercising. The WHO recommendation of exercise is 30 minutes moderate exercise, 5 days of the week. I would challenge a lot of people to think about whether they do that, but we're very quick to give our views as to what people should eat. And comes also opens up the whole debate about diet. There's always the diet wars, has been, it's not new, it's been going on for decades, centuries. And people always say that we can always advise diet. I think people also forget a lot of the role of privilege that a lot of medics have, and when they advise people what they should and shouldn't have. All I can tell you is that when you've got 3 jobs to hold down and you're thinking about how to feed your child, and 1 loaf of bread is all you can split between your children, advice such as you should really have bacon and avocado for breakfast doesn't really fly. So I think we need to be, you know, mindful of that. You know, it's very easy to give people ideas as to what they should and shouldn't have from our own position. Not everybody lives our own lives. So I think that's quite important. So life gets in the way, I think for me was very important. And I think this has always been a very divisive topic. Oh, should we call them a diabetic? Should we call them a person with diabetes? And I'll be very honest about it. There's a lot of people who don't mind being called diabetic. I think that completely takes away the debate as to what this is about. This is not about a politically correct term, diabetic. None that just ask the person what they would like to be called is my easy answer. But this is more about interaction, that 0.01%, just being a bit more human, being a bit more aware of what people are going through, and also appreciative that in that 10 minutes, 15 minutes, 20 minutes, whatever you have, they're not there to tick your box. If you find that they haven't done everything you would love them to do or want them to do, or they haven't had their blood test, it is what it is. It's life. I think you need to appreciate that rather than sort of saying you should have done this and you should have done that. It doesn't take us any forward, and there's no evidence it does. I know there are a lot of clinicians who still believe that what we should give is people a lot of tough love, you know, make them believe. Probably does work in a very small percentage. I would like to think about, I always like to practice clinical work in the way I would like my mom or dad or myself to be treated? Would I like to be shouted at by a doctor or nurse if I had diabetes? I can tell you 100% not. Would I like to be told off for not attending an education session because I was busy at work? Not really. So I think that then we need to be aware of the simple principle that we don't live other people's lives, and we don't know what challenges they have, what mental health issues they have, what social breakdowns they're going through, what work pressures they have. So, and I think if anything, the pandemic probably should make a lot of us in the NHS realize that not many people have had the opportunity to have a consistent salary, and work where we are at. So there is that too. From us, here was something that also came through in the research, and things like this: what's your diabetes control like? It was not, the problem was not with the question. The problem was that was the introductory statement. When somebody came in, there was no hello, there's no how are you, there was no intention to know the person. And this was a consistent theme from a lot of patients around the country, that the opening gambit from the healthcare professionals all about diabetes, nothing else. It felt like a business transaction. It felt like going to school. It felt like going to the headmaster's office or the headmistress's office. And that should not be the relationship, in my book, with people we are supposed to be looking after. Should you be eating that? Very common thing, very common sort of statement used. I have always done this when I do this face-to-face. I always say to people, all you need to do is go in the lunch breaks and see what people are eating. So how would you feel if I went around and gave advice about what you're eating? Nobody likes that. So on the other side, you can understand people trying to do it for the good of other people, for the good of the person you're sitting in front, but there are different ways of doing it rather than that judgmental thing. And I think here are throwaway comments which have been picked up, about nurses and doctors discussing amongst themselves. It's all very well to speak about it, but be aware of people whose lives you don't live, who might have the diabetes, the way they would see it. That's not a politically correct thing to say. It's not a politically correct issue. It's more about just being aware of what impact the words can have as you go along. So what we did, we created a document, which is a guidance. So just to make it very clear, it's not mandatory. I don't believe in making things mandatory. It's a guide. And I think that's what people need to see. Some of it is just simple common sense and simple human decency as we go along. Don't just dismiss it as a politically correct nonsense, because this is, if we genuinely profess to be listening to patients, I think it's something that you would want to sort of have a listen to or read of what people with diabetes are actually saying. So give it a try. Supported by all the relevant organizations, and most importantly, it's been created by those living with diabetes, which is very important, or it should be. At least we all profess and we sign up to those sort of things. So it would be good to have a look at it. The important thing is, it's a very short document. In historical terms, the NHS England always failed to do short documents. This one's about 6 pages long, of which 2 of the pages are introductory and the back page. So not a huge amount to read. If you find time, it's on the internet. It's very easy to have a look at. That's the document, what it looks like. Here are some things there which you might find. Seek to be less demanding, what you should and shouldn't do. Stereotyping. People of this background often dislike the idea of injections. Maybe so, from the 70s, but not always. Don't sort of go into it with a prejudged mindset as to what people do or do not like. Here's an example. People who come from different ethnic background, or they have much more fixed mix insulin in this country than others. And a lot of it is also down to stereotyping and believing, well, they eat different types of food, so let's just give them that. That works better. Don't be prejudging. Don't prejudge. That's what I think the view is. Shaming or blaming. Not all of us, I'm not sure about, I can't see everybody in the call, but I'm pretty sure not all of us are, prototypes of Angelina Jolie and Brad Pitt. We've all got issues as we go along. So don't point fingers at others when we're all struggling with our own lives and weights, etc. And I think this one I would like to actually point out, because this does irk me to an instant, because we talk in one hand about delaying and inertia. You'll have gone to many talks where people talk about inertia. But if you're going to use insulin as a threat, don't be surprised if people don't want to go on it. Insulin is a fantastic treatment. 100 years coming up, it is one of the cornerstones of diabetes treatment. And I don't think we should make it a threat. We should, in my view, basically say it's one of the treatment. Yes, we can work towards trying to see if you can stay off it if you've got type 2 diabetes, obviously not with type 1. But I don't think it should be a threat. And these were, as I said, these are not my views. These are views given by people with diabetes as to what they have heard, what they're seeing, etc. I seek to be more, again, trust building, some clear, empowering, collaborative. And again, I don't need to explain that to you. The document's all there. It's all supposed to be quite easy to read. Have a look at it. You might find it useful. There's also a website if you want to find time to have a look at it. And the website basically, so since we did the UK one, I've been involved in doing one for India, type 1 and type 2 English in different languages. I've been involved in doing a Spanish version, a French version. So different countries have shown a lot of interest. So this website has all those versions if you've got patients who would like to look at it into different languages. It's also got testimonials from patients. It's got some education sessions on it. It's got a host of things. It's got some leaflets. Have a look at it. It's a very simple website which was created and it's all the information that you need is there. If you find time, have a look at it, show it to your colleagues. You don't lose anything, but it should be part of your continuous professional development. And I know instinctively it feels like, is it possible that we don't do all this? There is very, very good data all around to say that what clinicians believe to be a really good consultation, a lot of patients don't actually believe it has been. So I think we like to think we do very well, but not always. At least this particular piece of work suggested there was still a fair bit to do in that particular arena. So I'm going to sort of try and wrap it up here with this quote, which I always like: the singer's biggest problem, and then communicates the illusion that it's taken place. We believe that we are having that conversation, though not quite so. So I think in summary, it's a document, it's a guide, it's not mandatory. Have a look. I'm not asking anybody to do something that is a fundamental change of thing. We instinctively believe, but I think that the lasting comment that I always say is that don't prejudge others whose lives you don't live. And I'll leave it there. Thank you very much.
Thanks very much, Partha. I think it's such a core issue, isn't it? The how we communicate with people. And it cuts right to the heart of what we're trying to do in our specialty. And I guess I've got some of my own questions. You'll know I'm not necessarily in my own practice the most effective communicator at all times. And I think one of the things that happens for a lot of us is we feel under pressure during a consultation to have achieved X, Y, check the screening results, fed back the screening results, discuss treatment, and done something. I think a lot of our surgical colleagues particularly would put a pressure saying, what did you do in that consultation? And I'm wondering, from the perspective of having effective communication, what would you say you would put as an outcome for a consultation to say, yes, I think, we can agree that really was a good consultation?
I think so. I think it's probably the other way around, because I think we, as you said, because of the pressure, right? Let's just take a pump clinic, right? Or a technology clinic. In our head, right? And quite rightly, you've got 15 minutes, 20 minutes, half an hour, whatever it is. And you're thinking, right, I need to see the download. I need to do this, I need to do that. And I need to make sure the next steps have been done to move on to. I think that's the challenge, because that person might have come in going like, I haven't been able to do anything, but I'm not sure how to take this conversation forward at all. I think the issue becomes is that, are we flexible enough to change the conversation to different areas? And I know you said that you may not necessarily be the person, but you do that. And I've seen that, because with patients come and say that, because when they come in and say, I'm really sorry, I haven't been able to do anything, there'll be a lot of people who go like, well, that's it then. Well, what can we do? Right, that's it. Right, fine. Let's meet again. And, you should have done the better. I think that stops that person from engaging with person X, not you, inverted commas, you anymore. But I think if you have the flexibility to say, all right, what's happened? Why have you stopped doing that? It's all right, life's just fallen apart. My mom's been ill and she's been in hospital, just haven't been able to do that. That, to me, I think that person leaving that appointment with a very clear plan for you to come back and interact again. I know there's a frustration, nothing's happened as a clinician. But I think my personal experience is that I think that probably gives the patient a lot more than you would have, because they will come back next time thinking, do you know what, at least you listened to me. Because most people will go into that appointment, if they don't know you, thinking, oh my God, this is going to go really bad because they're going to shout at me. And a lot of people come with that prejudged view, and then you held that. So I think for me, the outcome is if you've got a very clear plan and that person is happy that they're going to come back and start again. And what I say to healthcare professionals, I don't know whether you agree with this, I don't think necessarily healthcare professionals, probably more I'm talking medics, are necessarily trained in communication, which is a slight lack in our training program, that we don't quite go through the gamut of what do you do if somebody goes like, I haven't done anything, that sort of thing.
Okay, so we had a question from Kim in the audience who was saying, are there any particular tools that you would recommend people use in consultation? And I guess in context of the conversation we just had, the idea being to point people towards the conversation that perhaps needs to happen rather than the sort of directed one.
Yeah, let me just find that. Where was the question?
It's in
oh,
the
Kim,
chat
got
box,
Kim.
not the thing.
Is that
It's a fair way back now, actually.
Okay, all right. Well, I've got one from Kim. It's about the consultation tools and stuff.
Yeah, yeah, that's the one.
Yeah. I mean, I think outcome starts are a good guide to conversation. I showed you an example of where you pick the topics you want to talk about. So that a lot of people do use that. So to use a starting point, for example, what would you like to talk about today? And I noted a comment from below where from Rajiv was quite rightly saying, you got only 0.01%. Surely you want to talk about diabetes. Yes, but it has to be a conversation that makes them feel satisfied with you. You might talk about diabetes. They may thinking, well, actually, this is not at all relevant. I'm not listening. Nobody gets anything apart from your own satisfaction. And, I've been a consultant now for nearly 14 years, 15 years. I've had many conversations with people which has got nothing to do with their diabetes, but they come back and you start again. So I think that's part and parcel of that relationship you build with patient that you build. I think that's the way I would probably look at it.
And actually, we've just had an extra from that one from Luke in the questions box, which is saying, and what about resources to try and support people's dietary needs who with different ethnic backgrounds? Oh,
100%. I mean, I think that's the challenge, isn't it? We go with the set thing as we go along. So because it goes back to there's a lovely comment here from Kalika, which says that pressure to meet target. You're absolutely right. So those of you are aware, we are now. For me, diabetes, and me and Iain, Iain used to be my consultant. I've always believed in this. It's not about the targets. It's about the outcomes. Everything else is irrelevant. The NHS focuses so much on process. So Kalika, you'll be delighted to know we're working with the BPT team, which will be about outcomes, DKA and overall achievement, not about how many times have you phoned a patient, etc. And the same for adults as well. And I completely agree that we need to move away from the whole tick box where you're struggling to get your tick boxes done in that 15 minutes, but actually have a conversation with the person concerned. So I agree totally, and we are working on that nationally with the pediatric teams on that.
And I guess the issue about resources is one that comes up quite regularly, isn't it? And the challenge, I guess, most of us when we think of resources nowadays think often of online resources, don't we? And I think the challenge is keeping those current and appropriate and curated is quite difficult, isn't it? So I know you were involved with certainly one project, probably more around resources for people with type 1 diabetes. Is that something that you think is going to be formally taken on from an NHS England perspective, or are you able to?
Yeah, so I think with the explosion of what's happened, I think the last few years, the whole technology explosion, and I think there's much more to come when we're talking about closed loops and this and that. There'll be no question you will need more resource to deal with it. There's no debate about it. Without that, we cannot have closed loops everywhere. And we know that. I think Libra is a different matter altogether with Flash and all that sort of stuff. But I think as we expand more into the world of closed loops, that is certainly something we will have to look into. It does naturally ironically, it feeds in nicely into the narrative, because if we make a commitment to provide closed loops, it goes hand in hand with the narrative that you need to have the staff to deliver it. So which we have done, for example, with insulin safety. If a narrative is that we need to improve insulin safety, which is where you have to make investments towards having more specialist nurses or pharmacists, whatever. So that is going to be part of the going forward. But as I said, we need to set that with NICE to say that that's what is important for patients as we go forwards. And that has driven a lot of the resource uplift in pediatrics with the use of the best practice tariff in the past.
So we have a question from Laura. And he's talking about downloads and if they're done, and basically, would you suggest seeing the person before everything has been downloaded, or
or after. No, I'm quite relaxed about it, to be honest, because I think, to me, it depends as to what your clinic you're trying to get out of the clinic. So I think you will have a lot of patients who will be actually switched on, and you will straight away have all the downloads ready, and they are there. And you know the group of people who will do that as well. You probably will recognize them from your list, that everything's ready, right? You know that. There'll also be a lot of people who will need a lot of encouragement to do that. So I think it's a bit of a mixed bag on that one. I personally don't set any rules. I would definitely say I would like to have these, because it makes the clinic consultation much more easier if you've done the work before. But does that always work? Not really. And as I'm sure the same happens with you, Iain, doesn't matter how many times you've seen them. Have you done it? No. And you go out and download and everything.
And actually, what I was thinking when I saw that question from my own practice is to say, I think it's actually really good if people have downloaded before, and increasingly, certainly in this last 18 months, we've seen people who are downloading from home prior to clinics, which potentially makes things run much smoother. But I think there is a personal perspective that we have to take, which is to say, I would never talk about the download data as the first thing I talk about. I think we should be talking to the person as a person before we talk to them about their data.
100%. I think one good thing, what is starting to happen, and I think it's been fascinating for me, which I wasn't aware of, and I don't know what you think, Iain, is that as we are getting more awareness of time in range, it's quite interesting talking to patients and asking them, what do you think your blood sugar should be? And these are people who have had type 1 or type 2 for 15 years, 20 years, 25 years. And if you ask them, and I would ask all of you attending to do this as an exercise when you go, just ask them, what do you think forget about what you want to do and what you can do. What do you think all the professionals have been telling you? What is the impression you've taken, and what should your blood glucose be? And the majority of patients say, 4 to 7. And you go okay, how often? All the time? And then when you say to them, well, actually, 4 to 10, let's start with 50%. And then we go and you work out the time and rate. You see that and I think that's a very important language thing, to say that it's okay to be outside, because we will have patients who are chasing that there's that lone 13 and you're chasing it down. Why did I go 13 and all that? So I think that's been a big, big move forward in the language thing. And I think it's worthwhile you going and see, if you look at all the time in range data and how it triangulates to A1C, which is what we are chasing, the narrative to many people with diabetes that you need to be between 4 and 7 all the time, it's not necessarily what we have said. It's just what has been taken away. And I see that time and time again, the belief that they need to be 4 to 7. So I'd rather not check and know it's high. But on the other narrative being, actually, hey, listen, if you did 70% there, this is amazing. That means 30% you could be out. And then you talk about closed loops doing 78, 80% at tops. I think it just does change the dynamics of what you are saying is physically possible. And I finish with this bit, is that every single time I say to it, it is nearly physiologically impossible for you as type 1 diabetes doing MDI to get 100% between 4 and 7. It's a revelation to so many people when you say that to them. And I think that's an important part of the consultation, I think.
And I think the other language bit that I always try and use, particularly with the time in range processes, is to actually make sure I use the phrase time in a comfortable range. Yeah. Which is to say, 4 to 10 is our numeric target, but it's actually also our comfortable range. Yeah. So the issue is, it's where people don't have symptoms related to glucose. Above that, people will often have symptoms related to glucose. Below that, people will have symptoms related to glucose, but it's a comfortable non-symptomatic range. And I think that immediately puts you on the same side of the conversation then, because then actually that's what we would all like, wouldn't we? To spend as much 100%. Time as we can without symptoms related to my sugar levels.
100%. Couldn't agree more.
So we have people are reluctant to accept insulin, often because of its effect on potential for motor insurance and driving licenses, etc. How can we encourage such people to start insulin? There's a specific question for you, Partha.
Yeah, I think so. That's a big challenge. Again, it goes back to, we all will have that patient, that particular patient who is dependent on his black cab driving. Without that, he can't maintain his family, and thereby he's going to stay off insulin in whatever way you can, right? So there are no easy answers to that, simply put, because some people will go like, I don't care what happens to me. I just need to feed my kids right now. And I don't care what you say to me that my diabetes, we've all had those patients. I think the best you can do is give all the information possible. You can't force anybody, right? At the end of the day, you have to explain to them that the impact on the children, if he gets ill, and what do you do if he has a heart attack over the next few, whatever. I think without scaring, you can put the facts across as to why you as a clinician are saying so. And I don't think the difference is any much, for example, when we try and convince people to have a vaccine, right? You can only give the facts and say, in my opinion, and I tend to use a lot of the, if this was me, of if you were my family, this is what I would say. I'm not giving you anything separate to what I would have told my loved ones. That does work in some people it doesn't. But as I said, the analogy is with the vaccine thing. In spite of everything you do, there'll always be a cohort of people who will say no. And that doesn't make them anti-vaxxers straight away. There are some people who just do not want it. So I think there will always be a degree of that. You try your best, give the facts, not in a scary way, just to say your legs are going to. So you see a lot of that happens online. You go like, if you eat an ice cream, your legs are going to fall off. And you go like, okay, that's just ridiculous statement on its own right. But what does it actually achieve? Well, not a huge amount. So that, I think, is the narrative I sort of tend to go, especially with those patients, driving the insulin, and it's not uncommon to have that at all.
Yeah, and I mean, I guess the other thing, just to specifically to Suzanne's point there, which I'm guessing is about people with type 2 diabetes, is of course remembering that first injectable therapies in type 2 diabetes shouldn't, for most people, be insulin based. They should be GLP-1 based. And actually that is a very different proposition for most people, because you're looking at something which can potentially impact upon other factors other than just glucose levels. And of course, most of our first insulin users who have type 2 diabetes, we should have a specific indication around that, which is effectively that they're catabolic as a result of insulin deficiency for the most part, rather than, as it were, chasing an A1C number. I would say.
Yeah, I mean, Lisa mentions very important, the term non-compliant, and we have seen that so many times. And I'll give you one anecdotal, and you won't mind me sharing it because he has given me permission in case people say that, how are you sharing patient details? So there was a young chap who got admitted time and time again, and I think, just to put my hand up, I was in that group who basically said, young patient, just not taking their insulin, isn't it? And he was swear blind. He would swear blind because the prejudgment was, listen, he's a 19-year-old kid. He is basically loves his football, loves his drink. It must be he's just not taking his insulin. Yeah. What we found out subsequently, and I think that's part of my own learning as we've gone along, is that it was not that. He had broken up with his parents, so the council had given him a house, except that the council had given him a house which had no fridge. So he just left his insulin. He used to give his insulin. It's just the insulin didn't work. So you're sitting there and you're going like, oh, okay, that's a little bit embarrassing because I completely disregarded the view. And in my view, it was, it's a non-compliant patient just not taking their insulin. So I think, first of all, I think the term does nothing because, people don't take insulin for many reasons, not because it's fear, mental health, body image, or, as I said, giving you examples of just practical social issues. So I think non-compliant is just a wide term which says that you've given them some advice and they have said, I'm not taking it because I just want to die. I think that's a wrong term. And we are all non-compliant in everything in life. As I always say, when I do this session in a public forum, I always say, how many people has ever touched their mobile when you are driving? And there's your non-compliant, tag straight away, bang on the money according to rules. So, it is one of those.
And if people in this audience don't know, Partha is possibly one of the most non-compliant people I've ever met. But that's that's separate. I actually have a question of mine to add to that. So we've lived in unusual times, haven't we, this last couple of years, one way or another. And I was just thinking in terms of the sort of consulting conversations, the empowerment conversations and things like that, do you think that what we've been having to do around working virtually and with video and phone call consultations has put us backwards in that? Or do you think it's helped us in that? Or do you think that there are particular things that we can do better with one than another? I mean, what's your feeling?
I think if it's a new patient, somebody you haven't seen ever, I think I personally would like to see them face to face, because if there's the issue of the body language, there's the issue of what else you're picking up, which always isn't there on virtual settings. I think virtual is really good for people you know quite well, and they're happy to go with it. I think there's a lot of people who are uncomfortable with virtual, and they will tell you that, and they don't want to be shoehorned in that route. So I think virtual has opened up the dimensions of us probably reserving our face-to-face for certain groups, not for everybody. And I think that's not necessarily a good thing, because we'll all see patients where we go like, I did not need to see this person face-to-face at all. We could have done this on the phone. And I think diabetes lends itself beautifully to that, whether it's, if you think about it, you have to see some people face-to-face. You can't get around it. You're doing a joint diabetes vascular foot clinic. Okay, you have to. There's no two ways around it. You're doing a pregnancy clinic in majority of cases, especially when doing the scanning and everything. But a lot of our type 1 work, a lot of our renal work, etc., you might be able to do a fair bit. Sometimes you might want to see them face-to-face just to, just to simply do that physical review, which you may not be able to do it virtually, right? But I think to your question, I think it's opened up avenues for us to do. Our policy, or at least my policy, is that if it's a new referral or a new patient, I absolutely want to see them face-to-face. I see most of my other patients virtually, but I think on the list, if you pick up some people, I would, number one, I would say, I think that this one needs to come face-to-face. If they haven't been able to pick up the phone 1 or 2 times, I like to see them face-to-face to see that they're still in the system. And then finally, I ask them, in the next appointment, what would you like to do? And I can tell you that the majority of people say, nah, phone's good, or video is good. There'll be very few go like, can I come and see you? And I think it does skew a lot towards more of the elderly population who say, can I come and see you a bit more, which is fair enough. So I think that does open up avenues, I think.
So we've got a thorny question, which I wondered when this one would come up, from Karen, which is about, what about people who actually won't come to your clinics and won't attend? How do you work to try and engage that group?
So there are 2 or 3 ways of answering that. I think there is a system-wide answer I'll give, but I'll do the clinician first. So as a clinician, I think we have moved away, thankfully, from those days when you go like, 1 DNA out, done, not my problem, off you go. That is fantastic. And if anybody's still practicing that, please don't, because that is ridiculous. There's so many reasons people can't turn up. I think we should try everything we have in our tank. And I think we have to reassure yourself, and well, not only that, for also legal reasons, and for any sort of issues that crop up, that you've done everything. You've done the phone calls, you've done the letters, you've done the reviews, you've given them the appointments, you've done the letter to the GP, you've sent the letter to all of that. And I do all of those. So for example, if there's a patient I missed 3 times, given them a face-to-face, still not turned up, I will do a letter to the GP, copied to the patient, saying, maybe it's a miscommunication on our part, but I would like to see you face-to-face, right? Beyond that, there is a bigger question as a system, and this is something that I think we need to go out to specialist teams. So for example, there is an issue that we have around access to technology, right, in this country, which is more towards people who are, if you're less deprived, you get it. If you're more deprived, you don't. But a lot of it is because, if you look at the evidence, it's because the referral system that we have in this country is based on one simple funnel. The GP refers you the patient, you see the patient. If the referral doesn't come, or they don't turn up, they don't get the technology. So should it be that the specialist has got overreach over the whole system and can pull in patients? Or should it be the other way around, that patients have the right to refer themselves in by bypassing the GP? Now, unless we change that funnel, I don't think we'll be able to get on top of the problem that we have with deprivation. I'm not even talking about ethnicity. I mean, if you just look at our region, we are a fantastic mixture of really affluent people and really poor people. You just need to have the M27 in the middle and divide Gosport and Fareham, right? Huge difference in deprivation. And there's a perfect example is that, and we know for a fact that, we will not see many people from Gosport because it's very difficult to travel out. So what is happening to the people with type 1 or type 2 there? So there is that thing. So I think to your question, Karen, is that if they're young people not attending, I think medical legally and also for your own sake, you do everything you possibly can to reach out, and you have very clear trails about it, engage with the patient. You also have to realize at the end of the day, just like we talked about medicines, some people will not want to come. They are just not in the headspace. They don't want to come, or they don't want to see you. But are they having good care, or will they switch on at some point and come along? So you need the door open. So I think that's the best you can do. goes back to the point of, as healthcare professional, can we solve everybody's diabetes problems? No. Should we do the best we can? Yes. And I think, Rocky mentions a very good thing. Community DSM, absolutely 100%. Use the community teams. The reach out is either you as a specialist reach out to the community team, be part of it and help out. What you cannot do is sit there in the hospital and go like, if they happen to come, it's not my problem. That's the view I would have.
Actually, I guess one of the things that I think this sounds actually almost pathetic on my part, but one of the things that I think that the COVID rules have highlighted to me is how rarely pre-COVID, if someone didn't turn up, we'd just ring them instead. We'd say, look, the appointment was here, you didn't come. That's. But actually, of course, with COVID, we've been doing so much phone and virtual consulting that if somebody doesn't come, we assume it's because they thought it was going to be a phone call consultation, so we ring them instead. And often it's just purely that they've forgotten because they had other more important things on their mind at the time. But it doesn't mean you don't have a relevant conversation nevertheless.
Yep.
So I'm going to put two questions together that we've had, the last two from William and from Liesl, which I want you to answer in quite a specific way, if you can, Partha. And Liesl says, how do you begin a consultation and what's the first thing that you usually ask? And William has said, and do you have any tips for talking to younger people in a helpful way within the limited time of a consultation? So how do you start and how do you keep it going in a helpful way?
So my opening gambit, believe it or not, is how's it going? How are you? How's life? It's very open. It's very, very open. And you will get some surprise answers back. You will get some complete grunts back. You will get nothing back. But I think keeping it open is a good start because it opens the avenue up to, I also then ask about, so what are you doing nowadays? What you're into? How's it going? How's college, uni, whatever. And then I also try and pick up any little hints that they may have on what they have with them. So for example, if they've got a football kit on or it's something like a Marvel, things, you just try and find a common thing you can talk about, or you see something on the phone, something. I think it's, as I think somebody said, the first 5 minutes, you try and make that interaction. And that's what I do tend to do. Doesn't always work, because at the end of the day, to a young person, you're still an old foggy sitting there like somebody, how many of us when we were 17, 18 would really want to sit down with somebody who's in their 40s or mid 50s having a conversation? Not really much. You're sitting there going like, can I just get out of here? So there is that. I think that's quite important. But I think carrying on the conversation, I think once you find the common chord, I then always go with the diabetes. I go like, okay, what's going on? Is there anything I can help you with? How is it going? And I think I keep it as open-ended as possible. I also have a personal trick where I make it very clear that I have no idea what living with diabetes is. And I think for me, that's worked really well. I open my gambit by saying, to be very honest, I don't know what a hypo is. I don't know what pricking my fingers is. I don't know how to inject. So I will not be sitting here giving a lecture as to what you should and shouldn't do. It does switch on a lot of people, because I think they haven't heard that from a lot of people. And I think that does work as a fantastic icebreaker when you go like, I don't know what you're living with. So tell me, a bit like a Tom Cruise moment of help me help you. But I think what I do say is that, look, you're an adult and I deal with adults. We can lay out an array of things for you. You can read this resource, be on the internet, whatever. If you find something, that ask. And this is why I'm here. Here's my contact detail. So that's all I can do is give accessibility, be open. Sometimes it works. Sometimes it takes more than 2 or 3 appointments to break the ice. So that's my sort of, and I tend to be quite relaxed in clinic. As those of you will know me, I do my clinics just like I am right now. So in my, t-shirt and my relaxed jeans, and sit down and chat and try and not appear as too distant as much as possible.
So Laura's making a statement at the bottom there, saying, but surely if you do download someone's device, you're setting the agenda for the meeting anyway by the fact that they've got their device being downloaded. Is that true, do you think, always?
No, I think that's why I wouldn't do that for the first meeting. I just wouldn't. I would basically talk to them about, I think once you build that relationship, you will know from that person whether they want to download or not. Sometimes people want to download it themselves. And I would tend to sort of rather basically say, look, you have the option to download it. I always say, if you are not in that headspace, that's fine, but let me know. We'll pick up another conversation. So I don't physically download. And I think Emma asks a really good question, which is, how do you find out what drives a patient to manage their diabetes without asking that question? What are their goals? So I think if you ask, I do ask that question. So what is it about diabetes that bothers you most? That's what I say. And a lot of people say living with it. That's what they say. So what can I do to make it so I always say that, look, I know ideally you would want the cure. We don't have it. What's the next thing I can do to help you? So it's very rarely young people come out and say, you know what I really want to do is not have a heart attack. They don't, right? Their main concern seems to be eyes. Eyes is a big thing. And their feet. I don't want to lose I always do say that. So for example, one of the tactics or one of the conversations I always have is that, so for example, if somebody's 17, I say, look, you're 17, I'll tell you what we want to do. When you're 67, I want you not to have any problems with your eyes or your kidneys or your feet. And they all agree that's what they're here for. Death, heart attacks, and all that are all old people's thing. They're not fussed. Eyes, kidneys, big thing. So generally speaking, I tend to open it up. I tend to sort of drop a few things that always does help. And, and I think Lisa makes an fantastic point, because that's also a question that I ask, what works? What is it that works? And Lisa is absolutely bang on the money. We are always problem focused, and that's not our fault. It's because we have that, we go like, right, we need to solve a problem, right? But sometimes it isn't. And I'll give you one another example. It's time in range, right? People come in with time in range of 15%. And I say to them, hey, listen, your target is, you know what? Your target is 20. That's all. And if they come back and you never tell them if they failed, you go like, that's all right. You one step back, we'll try again. Let's just try a little bit. Let's try 17, and I think everything you do has to be encouraging as much as feasible as you go along. So, celebrating no hypos for a week, massive. You sit down and go like, look at the steps you made. And I think it's, as I said at the very beginning, 99.9% they live on their own, right? With a particular pathology, which is unforgiving. I always say type 1 diabetes is unforgiving, unremitting, right? So in which case, you, in that little time, you can be a nice little support as well and be encouraging as much as you can do. A bit like school. You always remember the school teachers always said, oh, you got 3 out of 10. That's much better than 1. And you go like, oh, it's not that bad. Even he found that very good. So yeah, it's a bit like that, I suppose.
I mean, I guess it boils down, doesn't it, to the fact that we're trying to communicate with the person, not with the disease. We're trying to manage possibly the symptoms, etc., of a disease, but the person we're communicating is the person, not the disease, isn't it? I think so. Those sort of human touches, I think, have to be the key starting point, don't they?
And I think the process thing. Don't forget that we've got 2 basic process systems that we have in the system. One is for people in the primary care, the adults, where they have to go through X, Y, and Z. A lot of people don't find that useful. We find it as a system. Don't get me wrong. As a national policy, they love it because it does outcomes. Individually, there's not many people who go like, do you know what happened today? They checked my feet. It was amazing. And they called me in and it was so good. No, they don't. Lots of people go like, oh my God, here we go. They're just calling me in to tick a box because there isn't that broader realization. And then we have a lot of children who come across and go like, oh my Lord, it was a bit like I was being stalked, right? They would phone me all the time and email me and what's going on? And it's so, but it helps the system. So I think we need to somehow understand, make that process a bit simpler, that we're not doing it for us, we're doing it to help everybody. So I think that's easier said than done. I think that's the problem.
So we're getting up to the top of the hour, actually. But what I wanted to make a comment. So Suzanne has made a comment about perhaps that there are too many virtual consultations, and is this really a better trend? And actually, just from a personal perspective on that, I think we've certainly had some feedback from some of our group who are absolutely clear that they prefer virtual to face-to-face consultations, if only because they get to drive the conversation much more. When you're having a conversation on a computer, it's very difficult to sort of get distracted by saying, oh, had I better look at your feet, or had I better... It has to be about what would you like to talk about today, to some extent at least. So actually, I don't think we should palm off virtual and say, no, that's not what we should be doing, because actually I think we can often achieve more from a communication perspective in virtual than we do. Clearly, we don't necessarily build up the same rapport around body language and the feeling that we've had that group experience. But I'm interested by your thoughts on that too.
Yeah,
Partha.
well, I mean, I always say, we talk about choice, right? That's been the mantra for the NHS. But let's give choice. Let people choose what they want to do. It's not for us to dictate the agenda. We've had the same issue with education, haven't we? We shifted now. But it was 5 years ago, we would say that the only way you can get education in type 1 and type 2 diabetes care was actually coming to a clinic or an office or a group or everybody sitting together. And there'll be so many people who go like, I actually don't want to sit in an office. I don't want to sit down with strangers. I just, or I can't get time off. What's going on? I think it's not one or the other. Blend it up. And I think that has to be the right approach. And I always say to people, just look at how we watch movies. You can sit at home, put the Netflix on and watch Squid Game. You can also say, do you know what? I'm going to go and watch Bond in the theaters. Both of them has to be an option. And I think that is a fundamental part of what we do with care. So if we do that with movies, why on earth would we not do it with healthcare? Especially when people are saying, hey, this works for me, this doesn't. So I think it's a mixture of both, and having that blended approach works really well.
So I think we can absolutely tell that this is a Partha conversation, because there have been at least 3 references to cinema, Marvel, and comics, which means we definitely know that this is Partha's true views. I think, as I say, we're drawing to the end of the hour, and it looks as if we've got comments coming in that are largely drawing together comments as well. So at that point, I'm going to hand back to Hope, who will just finish us off, I guess.
Brilliant. Thank you very much, Iain. Thank you, Partha. That was fantastic, really interesting. I've certainly learned a lot, and I hope that all of you attending have also really enjoyed it and learnt an awful lot as well. Thank you, Iain, for doing a wonderful job of chairing the event. So thank you very much. Have a good afternoon and goodbye.
Thank you.
Thanks, everybody.